328, page number, section 3, endocrine. So we are talking about the physiology. We'll be continuing from the last video. So physiology, in physiology we start with the hypothalamic pituitary hormones. These include, on the left side we have all the hormones and their function, and then we will go for the clinical notes. First is ADH. ADH function, it causes increase in water permeability of distal convoluted tubules and collecting duct cells in kidney to increase water resorption. Clinical notes is it causes stimulus for secretion in increase in plasma osmolality, except in SIADH, in which ADH is elevated despite decrease in plasma osmolality. CRH causes increase in ACTH, MSH, and beta endorphin, which causes decrease in chronic exogenous steroid use. Which will cause a decrease in chronic exogenous steroid use. CRP is decreased in chronic steroid use. Dopamine, it causes decrease. Its function is to decrease prolactin and TSH, thyroid stimulating hormone, also called as prolactin inhibiting factor. Dopamine antagonist. Dopamine antagonists are antipsychotics. Can cause galactorrhea due to hyperprolactinemia. GHRH, this is growth hormone, growth regulating hormone. It causes increase in growth hormone. Analog is tesamorelin, used to treat HIV-associated lipodystrophy. GnRH, this causes increase in FSH and LH. This is suppressed by GnRH is suppressed by hyperprolactinemia. Tonic GnRH analog, which is example leuprolide, suppresses hypothalamic pituitary gonadal axis. Pulsatile GnRH leads to puberty and fertility. As we know, FSH and LHS is seen in the menstruational cycle, where it increase in FSH and LH cause the ovulation. MSH is increase in melanogenesis by melanocytes. Causes hyperpigmentation in Cushing syndrome, Cushing disease, as MSH and ACTH share the same precursor molecule, pro-opiomelanocortin. Melanocyte stimulating hormone is basically causing increase in melanogenesis. These are melanocytes basically, which are our skin color. Oxytocin causes uterine contractions during labor, responsible for milk letdown reflex in response to suckling. Modulates fear, anxiety, social bonding, mood, and depression. Prolactin is decrease in growth. GnRH stimulates lactogenesis. Pituitary prolactinoma, amenorrhea, leads to amenorrhea. Osteoporosis, hypogonadism, galactorrhea, Breastfeeding causes increase in prolactin, causing decrease in growth hormone that will lead to delay postpartum ovulation and natural contraceptive. Somatostatin is causes decrease growth hormone and TSH, also called growth hormone inhibiting hormone. GHIH. So basically somatostatin is an antagonist for a growth hormone here. These are not friends. Analogous used to treat acromegaly. TRH is thyroid regulating hormone, causes increase in thyroid stimulating hormone and prolactin. Increase in TRH, example in primary or secondary hypothyroidism, may increase prolactin secretion leading to galactorrhea. Here you have the detailed picture how each of them are affecting the as we said, GnRH causing LH and FSH, and this prolactin is inhibiting GnRH. Here everything is diagrammatic. If you like to see this one, understand this one, or by going word by word, you can go. And growth hormone. Growth hormone is also called somatotropin, secreted by anterior pituitary. Stimulates linear growth and muscle mass through GF1, somatomedin C secretion by liver. Increase insulin resistance, diabetogenic. Released in pulses in response to growth hormone releasing hormone GHRH. Secretion increase during exercise, deep sleep, puberty, hypoglycemia, and CKD, chronic kidney disease. Secretion decreased by glucose, somatostatin, and somatomedin, regulatory molecules secreted by liver in response to growth hormone acting on target tissues. Excess secretion of growth hormone, example in pituitary adenoma, may cause acromegaly in adults or gigantism in children. Treatment is by somatostatin analog, octreotide, or surgery. Here you can see diagrammatic representation of all the things we have said in words over here. You can see the inhibition sign and the activation sign. The antidiuretic hormone, so also called as vasopressin. The sources are synthesized in hypothalamus, supraoptic and paraventricular nuclei, stored and secreted by posterior pituitary. So it is formed in hypothalamus and then stored in posterior pituitary. Function is to regulate blood pressure, V1 receptors, and serum osmolality, V2 receptors. Primary function is serum osmolality regulation, ADH, decrease in serum osmolality and increase in urine osmolality. Y, regulation of aquaporin channels, insertion in principal cells of renal collecting duct. ADH levels is decreased in central diabetes insipidus, DI, normal or increase in nephrogenic DI. So in central it is decreased and in nephrogenic it's increased. Nephrogenic DI can be caused by mutation in V2 receptor. Desmopressin ADH analog is a treatment for central DI and nocturnal uresis. Regulation plasma osmolarity, the primary or hypovolemic. Prolactin. Prolactin is secreted mainly in anterior pituitary, structural homologous to growth hormone. Function is stimulates milk production in breast, inhibits ovulation in females and spermatogenesis in males by inhibiting growth hormone synthesis and release. GnRH release, sorry. Excessive amount of prolactin associated with decrease in libido. Regulation. Prolactin secretion from anterior pituitary is tonically inhibited by dopamine from turboinfundibular pathway of hypothalamus. Prolactin in turn inhibits its own secretion by increased dopamine synthesis and secretion from hypothalamus. TRH increases prolactin secretion in primary or secondary hypothyroidism. So you can see this in increase in TRH, prolactin secretion in primary or secondary hypothyroidism. Dopamine agonist, example bromocriptine, inhibits prolactin secretion and can be used in treatment of prolactinoma. Dopamine antagonist, example most antipsychotic or metoclopramide and estrogens, example OCPs, oral contraceptives. Pregnancies stimulate prolactin secretion. So this is a diagrammatic representation again. You can see here slide or cry of the baby can cause higher cortical centers to inhibit hypothalamus formation of prolactin. Thyroid hormones. Thyroid hormones are produced. Thyroid hormone produces T3, which is triiodothyronine and thyroxine. T4, so T3, T4, iodine containing hormones that control the body's metabolic rate. So as you can see, iodine is the main thing that can that is forming the T3, T4, TSH regulating. If you have like low iodine in your body, you can see defects in the in this organ. Source: follicles of thyroid. You have like it's a shape of follicle like this, like a butterfly, and you will see smaller follicles in them. Here you have 5-deiodinase converts T4, the major thyroid product, to T3. So first it is T4, then it's converted to T3 in peripheral tissue. 5-4-3. Peripheral conversion is inhibited by glucocorticoid, beta blocker, and propylthiouracil (PTU). Reverse T3 or T3 is metabolically inactive byproduct of peripheral conversion of T4, and its production is increased by growth hormone and glucocorticoids. So when there is increase in thyroid hormone, you don't want too much of thyroid in the body, so there is an inhibition reaction which will cause this T3, this formation of T3 reversed into T3 to become inactive, so it's not absorbed. This is done by growth hormone and glucocorticoids. Function of thyroid peroxidase include oxidation, organification of iodine, and coupling of monoiodotyrosine (MIT) and diiodotyrosine (DIT), inhibited by PTU and methimazole DIT plus DIT, which will cause formation of T4. DIT plus MIT will form T3. Wolff-Chaikoff effect, you can pronounce it in your accent, A Wolff-Chaikoff, maybe if Wolff-Chaikoff effect. Excess iodine temporarily turns off thyroid peroxidase, which will cause decrease in T3, T4 production. Protective autoregulatory effect. Function of thyroid hormone is only free hormones is active. T3 binds nuclear receptors with greater affinity than T4. T3 function is 7 B's to remember. B for brain maturation, bone growth, synergism with the growth hormone, and beta-energetic effect, which is causing increase in beta-1 receptors in heart, which will cause increase in cardiac output, heart rate, and SV. SV is and contractility. Beta blockers alleviate adrenergic symptoms in thyroxicosis. Basal metabolic rate increase, which will cause which is caused via sodium potassium ATPase activity, which will lead to increase in oxygen consumption, respiratory rate, and body temperature. Basically, the thyroid is controlling the heart, bone, and respiratory rate, temperature. Like it's one of the main component in regulating the vitals. Blood sugar increase in glycogenolysis and gluconeogenesis. Breakdown lipids causes increase in lipolysis. Stimulates surfactant synthesis in babies. Regulation. TRH causes TSH release, which will further cause follicular cells. Activate follicular cells. Thyroid stimulating immunoglobulin TSI may activate follicular cells in Graves' disease, have a positive effect on follicular cells. Negative feedback primarily by free T3, T4 is anterior pituitary causes decreased sensitivity to TRH, and hypothalamus, in hypothalamus it will cause decrease in TRH secretion. So you can see over here anterior pituitary of getting a feedback from high T3, T4, and this also can cause negative effect feedback on hypothalamus. Basically, it's telling the hypothalamus stop, like we have a lot of T3, T4, we don't not need anymore. Thyroxine binding globulin, TBG, binds most T3, T4 in blood, bound T3, T4, causing inactive. Here you have increased TBG in pregnancy, OCP use, estrogen causing increase in TBG, which will lead to increase in T3, T4. Decrease in TBG, thyroxine binding globulin in steroid use, and nephrotic syndrome. Parathyroid hormone. Parathyroid, as we know, it's the it's sitting right behind the thyroid. These small little pairs, 4 pair. Usually, it's the most common type is 4. Having 4 different people may have 2 or 3, or it depends. The most common is 4. Parathyroid hormone. Parathyroid glands I'm talking about. This parathyroid glands will secrete parathyroid hormone. These are the parathyroid hormone is secreted from the chief cells of parathyroid. Their function is causing increase in free calcium in the blood. This is the primary function. Increased calcium and phosphate absorption in GI system. Increase in calcium and phosphate from the bone resorption, and increase calcium resorption from DCT, and decrease phosphate reabsorption in PCD. Increase in 1,2,5-OH2D3, the calcitriol production by activating 1-alpha hydroxylase in PCT. Try to make D3 in the PCT. So it's a mnemonic to remember. Basically, this is the one you need to break down the vitamin D, and so that the calcium can get absorbed. I hope that's right. You can check again on internet, or maybe you know if you know. The PTH causes increase, the parathyroid hormone causes increase in serum calcium, decrease in serum phosphate, and increase in urine phosphate, and increase in urine CAMP. Increase in RANKL, RANKL receptor activator of NF-kappa B ligand secreted by osteoblast and osteocyte, binds RANK receptor on osteoclast and their precursors to stimulate osteoclast and increase in calcium, hence causing bone resorption, intermittent PTH release, and also stimulate bone formation. PTH is phosphate trashing hormone, so you can remember it by this, like phosphate trashing hormone. Here basically parathyroid is it's like developing the bone and helping the bone resorption, and when it's breaking down, you can immediately take up the throw out the phosphate in the urine, and utilize the calcium that is breaking down so that it can turn it back into the bone. So that's what it's trying to say, phosphate trashing hormone. So it's gonna increase the urine phosphate and serum phosphate. PTH related peptide PTHRP function like PTH and is commonly increased in malignancies, example in squamous cell carcinoma of the lung and renal cell carcinoma. Its regulation, so parathyroid hormone is regulate calcium, as we said. Decreases serum calcium and increases pituitary PTH secretion. It causes increase in serum phosphate. Then it will. So when there is decrease in calcium, this is sensed by the parathyroid hormone, hence causing increase in the parathyroid hormone. So it can take up the calcium, whatever is in the blood, and bring it back to the bone and in the serum. When it detects a lot of phosphate in the blood, then it will cause activation of PTH, and when it detects a decrease in magnesium, it will also cause activation of PTH secretion. It's basically like whenever anything of, and it's a supply and kind of management. Whenever there is a shortage of any of the of its components, it will immediately detect it and bring it back, store it in. Decrease in serum magnesium, a lot of decrease, high decreased, then it will cause a negative feedback on PTH secretion. Common cause of decrease in magnesium include diarrhea. So when there is when there is a normal diarrhea or even excessive diarrhea, in such cases like intestinal infection, C. difficile, so infection, then you can have excessive diarrhea causing excessive decrease in magnesium, which can cause decrease in PTH secretion, and you can have like more complications.